Hey, this is Sandy.
And Randy.
And we're here on AT Corner.
Being an athletic trainer comes with ups and downs, and we're here to showcase them all.
Join us as we share our world in sports medicine.
Welcome back to another episode of AT Corner. For this week's episode, we have an education episode focusing on lateral ankle sprains.
The basics.
Yes, and this is the cool part. This is an update from our last time we talked about lateral ankle sprains, which was about 5 years ago.
That is pretty cool. It's like full circle, literally.
It really is. It's kind of cool to provide an update of here's where the literature is at now.
Also, just to think of the clinicians that we were 5 years ago.
Oh no, that's scary. So much time has gone.
Yeah, so like Randy said, this is a CEU episode. So if you are listening to this as it comes out, it is a free Category A CEU. And if it is not, then it is purchasable and very affordable. Thank you to our partner, Athletic Training Chat and Clinically Pressed. So if you're interested in getting your certificate for those CEUs, make sure you scroll down to the show notes below where there's a link. Fill out the course evaluation and watch the video and take the little short quiz that has unlimited attempts, I believe.
I believe so.
So once you do that, your certificate will be generated for you.
Yep, absolutely. So for this update, we will be discussing the current evidence on the rehabilitation following lateral ankle sprain. We'll discuss the role of the medial ankle complex in lateral ankle sprains. Don't worry, you heard that correctly. And then we'll also discuss some return to play considerations, which
Sweet.
Interestingly, I looked back at the older episode, which was episode 50, by the way. Fun facts today.
Wow. And we're almost at 250, so 200 episodes later.
Isn't that crazy?
Insane.
And we really didn't talk that much about in-depth rehab or really return to play. So this is kind of cool. At least it's some new stuff, not just kind of same old. So that's awesome.
Are we starting with anatomy again?
Of course we are. So what role exactly does the medial ankle kind of play with lateral ankle sprains? And really when we talked about ankle sprains last time, it was mostly focused on obviously the lateral side and even the subtalar ligaments. So this time I wanted to spend a little time on, well, what happens to the medial? And for the medial ligaments, we're really going to be focusing on the deltoid ligament. It's ginormous, so it's a good place to start. Mm-hmm. And as you dive deeper into learning about the deltoid ligament, I feel like there's a lot of information that I'm like, man, I never knew that. I feel like we weren't taught this in school. So the deltoid is going to be made up of 6 ligaments. Literature is kind of debated on 6, 8, 7.
Interesting.
Yes. But most things that I've seen has kind of been geared towards 6. And it's divided into 2 layers. So you have the superficial layer, which has 4 ligaments, and then the deep layer, which has 2 ligaments. All right.
Depending on where you look.
Yeah, exactly. That's how it always goes, depending on what literature you read. But for the most part, what I've seen consistently was about 4 and 2.
Okay.
So what the deltoid is supposed to do, what it biomechanically is trying to achieve, is the deltoid resists external rotation of the talus, so the talus kind of rotating laterally, and posterior translation of the talus, which if you're listening to this, you're like, I still don't see how this has to do with anything with ankle sprains. But what's interesting is the deeper layer, so those deep 2 ligaments, actually resist against valgus and lateral translation. And I think that's where you get to see most of where there could be damage with the deltoid ligament in a lateral ankle sprain.
Lateral translation, I feel like you don't hear as much.
I know, right? But what was interesting, what kind of got me thinking about, man, I think we really have to include this, is a lot of the studies looking at the deltoid ligament, when they would go in for reconstructions for the lateral ligaments, a lot of studies were reporting tears in those deeper ligaments, showing that these ligaments do serve a role in stabilizing the lateral side, even though they're not on the lateral side. Mm-hmm. So I thought that was very interesting and something to keep in mind, because how many times have you had someone with an ankle sprain that they start migrating their pain and it's kind of anteromedial, medial. Oh, it's kind of like deep in there. And you're like, this is your lateral ankle sprain, dude.
I feel like I've always attributed that to either the like compression forces that happen in an ankle sprain or like the swelling, the like diffuse swelling that kind of translates over there.
Yeah, for sure. But this kind of gives you another kind of game plan on maybe we could see maybe some tearing in there as well. So that's kind of giving you an overview of how the deltoid will kind of factor in on lateral ankle sprains. So as we look now gearing towards our rehab, the last time we talked about lateral ankle sprains, it was kind of more kind of conceptual, like, oh, you should do some mobility, like do some mobilization. That's good.
You should rehab it.
Yeah, yes, exactly. But this time we're actually going to dive a little bit deeper into what happens after the ankle sprain.
Okay, cool.
Right? How can we actually address some of these problems? And as with any injury, if you've followed along this long, especially when we're talking about a joint, the neuromuscular system isn't super jazzed that there's an injury. And
Goes on high alert.
yes, exactly. And we see a lot of neuroplastic changes similar to what is often described in like the ACL research, right?
Oh, interesting.
Yes. You start talking about like, oh, inhibition and like all this bad stuff. It's actually very similar to, or it's actually the same in lateral ankle sprains. You see inhibition, you see the motor cortex starting to change, all that stuff. You like assume, oh, like ACL, like duh, it's surgery and it's a big ligament that's damaged. But same thing happens with ankle sprains.
Well, doesn't inhibition in the like post ACL come from the swelling in the knee? Actually, inhibition of the quad comes from that.
Yeah, and
so inhibition, where does the inhibition happen in lateral ankle
it would be the
sprains?
same idea. It'd be the same idea about the swelling in the joint.
No, I know, but it's not the quad that's.
Oh, it's actually gonna be a lot of the surrounding musculature, tibialis anterior, peroneus longus, all start to see inhibition.
Okay, so that's why you're just doing all the like 4-way ankle and kind of like band work and kind of like activation stuff.
Yes, absolutely. And so, like I said, we do start to see the inhibition of those musculature. And if you really wanted to dive deeper into this inhibition, it's especially noted in Sandra's favorite type of inhibition, and that's the spinal reflex inhibition, also known as the H reflex.
No.
Which basically the H reflex is basically the reflex arc from the spinal cord to the muscle. So it's a quick way of your muscle activating really quickly. That is inhibited, which when you think of when you roll your ankle, your peroneal should grab it really quick. That's a reflex, right? So if that's not working very well anymore, you can see, oh, maybe.
I feel like that's a bad adaptation.
Yes. It's not ideal, and hence why we have to address it.
I feel like sometimes that makes sense. Like your quad not firing after your ACL makes sense because then you don't want excess forces to shift your tibia anteriorly. But I don't really.
Other things turning off.
Yeah, yeah.
But it's also important to note that these changes aren't really seen locally either. Like obviously you're going to have that inhibition, and there's actually again more evidence that shows like the peroneals will start to atrophy, right? The tendon starts to shrink as well. Like you can see that there's less activation there, similar to again what we see in the quads after ACL post-op as well.
Peroneals equal quads. Okay.
If that is the action item for this episode is peroneals equal quads. We should make a sticker for that. But you can also see these changes in the brain as well. Again, similar to what's seen with ACL, to where there's actual postural impairments. So like balance goes down the pooper with like post ankle sprain. And it's because in the motor cortex, more areas are firing to achieve such a simple task as balance.
I think this is really fascinating. Like when I've learned about this in the past, I just want to listen to so much about it.
Yeah. Like a simple task like balance shouldn't require much motor activity in the brain, but for those that have ankle sprain, more areas are firing to kind of compensate for the lack of information from the damaged ligaments, the inhibition that's happening in the peroneals. So now it's like, well, I lost that information. The brain's like, I need to find this information from everywhere else. And it creates a lot of activity, and then the brain starts getting confused. Next thing you know, your athlete can't balance, and you're like, dog, that was trash.
So this is exactly why dual tasking is such a big push right now.
Correct.
Because then we can decrease the activity needed because the brain is working on other things.
Correct. Yeah, absolutely.
And it doesn't have to focus on actually doing what it should be doing.
Yeah, and we had a whole course in this for our doctorate, which talked about all that. It was
really,
awesome.
really awesome.
It was awesome.
Actually, probably one of my favorite courses.
Yeah, absolutely.
So, okay, what do we do about this?
So there are some kind of techniques that we can do to kind of break inhibition to give us a window to actually start trying to get more activation in. And TENS, cryotherapy, manual therapy have all been demonstrated to reduce inhibition. Right.
So we can do that on like the peroneals.
Yep. Or like the ankle joint itself.
Okay.
Yeah.
To like TENS on the ankle joint, cryotherapy, cryokinetics.
Yeah, I would say so. Yeah. Cryokinetics.
Manual therapy, like in general.
Yes. Really, yeah. Any like soft tissue work, anything that's going to stimulate the mechanoreceptors to decrease pain.
Okay. So
would
just
be
getting
able to do
pressure
that.
on that.
Yeah. But TENS and cryotherapy are going to be more effective at reducing inhibition than manual therapy, but manual therapy still has a place. And there are...
So when people say that they don't do ice anymore, like there is a time and a place, right?
For sure.
Cryotherapy is great for inhibition. It is so great for
It's
inhibition.
actually been shown to be very effective. And a lot of that is coming from the ACL research, of course. But it's the same idea, right? You're decreasing that pain stimulus that's causing the inhibitory pathways, right? If you block that, well, the inhibitory pathway is going to chill a little bit. Now there's a window that you're like, hey, we can get some activation in there. Right. So again, you can pair TENS, right, with your activity. And like, it doesn't have to be while you're doing it. You can, right? You can do, I've done that before, but you can do TENS first for your treatment. And I think the effects of it last about an hour. I think you have about 40 minutes to an hour to where the inhibitory signal's like suppressed.
Oh, that's
so
cool.
You could do your TENS first and then just jump into your exercises too. Because what I like to do is, because a lot of times I'm by myself. So it's really hard for me to do like effleurage all the time. So what I like to do is I'll do like the Normatec boots. And then while they're doing the boots, I do TENS too.
Oh, okay.
So I do them both. So I get double the treatment happening. All right. So
we do the same thing with like a game ready.
Yeah. Yeah. Ooh. Double the treatment. So that's a great start already to now set your rehab up to be even more effective than if you were still dealing with the inhibition. There is still good evidence based on kind of what we already know about. We're always told like, hey, you want to get that ankle moving as soon as you can. You really don't want to immobilize it if you don't have to. And that evidence stays true. Early mobilization is still the best, especially when you pair it with those modalities that break inhibition, right? So making sure that you do your TENS and then work on your strengthening and mobility stuff there, that'll be the best. It's even interesting, even if you have to immobilize them, doing isometrics while they're immobilized actually shorten the return to play time compared to just being immobilized.
Like shorten significantly? Like, do you remember?
Yes. I can't remember how many days, but it did statistically significantly reduce that time to return to play.
I mean, it makes sense.
Yeah.
I love isometrics.
Yeah, so that's a good place to start.
People skip them.
Yeah.
It's pretty easy to skip.
It does. I do feel like it gets forgotten sometimes.
I feel like it gives people something to do when they have nothing to do.
Yeah.
That's why I like them.
Yeah, and it can serve a purpose. Again, when you pair it with these modalities and stuff, boom. Now you've made isometrics even better.
Look at that.
Look at that. So now that you've done the rehab and you're ready to, hey, let's get back out there. Let's go play. There are some things to kind of keep in mind. There are more studies that are coming out for return to play specific for like ankle sprains. Again, like an ACL has a ton, right? We've studied the hell out of hop tests for ACL, right? So it's really nice to see ankle sprains starting to come up, especially when you think about ankle sprains, like they are the most common injury. So to actually have this literature is really good. There's a new system that's coming out to kind of evaluate return to or readiness to return to play, and it's called the Ankle Go. Yes, it's basically made up of the Star Excursion Balance Test, but in reality, they're doing the Y balance test because they're only doing like three angles instead of the Star Excursion, which I think is huge. I think it's
Interesting.
I think it's like 9 different angles.
Okay.
But I don't think they can call it Y balance test because probably copyright. Figure 8 hop. So if you're not familiar with that, you have 2 cones. I can't remember the distance, but you have 2 cones, and basically the person hops in a figure 8 around the cones.
So, I have to see. I've never heard of this one.
Yeah, neither did I. I read up on it. I was like, wow, that's really cool. Basically, they go around twice and you time them. So you're measuring the time that it takes.
Like, where do they hop? Like, are there specific stops along the 8 that they hop, or is it just like have to?
It's just the 2 cones, and they have to like hop around it, creating an 8.
I know, but like, is it like 1, 2, like in between the cones, and then to the left of the cone, and then in front of the cone, and then side?
Ooh, good question. I didn't notice that.
Or is it just like make your way around the cone on one leg?
I think it's make your way around the cone on one leg.
Oh.
Yeah, I didn't notice that when I was reading it. Might have to look back.
Yeah, I want to look into this.
Yeah, that's a good point. Medial lateral hops. You might see it referred to as side hops, right? It's just, I think it's
On one leg?
yeah. It's I don't want to say it wrong now. I can't remember the distance that it is, but there's a distance that you have to hop, basically.
All of the references is a great time to say.
Yes.
All of the references are on our website, so if you go down in the show notes below, we'll have that link as well. So if you want to look more in depth of these, we'll have them in the references.
And the great description on them, and great description on the cutoffs for each one, which is going to be my next point. But the medial lateral hops, which is basically jumping X amount of distance.
So basically what I'm seeing is, sorry to interrupt you, I'm seeing a balance
Yep.
with like a reach component or like a range of motion component. And then I'm seeing a change of direction kind of hop. And then I'm seeing a side to side kind of hop. And then the part that you haven't said yet.
Yeah. So with the medial lateral hops, I think it's 30 centimeters. But basically you go 10 times and then you time them.
Okay.
Get a time. And then finally, they utilize 2 patient-reported outcome measures. So the foot and ankle ability measure, or the FAM. I like to call it FAM. I don't know if anyone else does, but I think it's fun. FAM. And then the ALR RSI, which is ankle ligament reconstruction return to sport index. Yeah. They made one basically like the ACL one, but for ankle surgeries. Basically, it's their.
But you can only use this if someone has had ankle surgery?
No, that's what it was initially designed for.
Oh, okay.
But they are applying it for this. It basically is just the athlete's perception of their readiness from their ankle injury. So basically, they made that up, made a total score of like 25. And this has been validated to actually detect those at risk of having a recurrent ankle sprain at 1 year post-injury. I think if it was below the score of 8 out of 25, they were 9 times more likely to have another ankle sprain.
That's significant.
Yeah. So this can help kind of give you an idea of, okay, who's really ready to play? And then you can kind of create that cutoff, right? If you have someone who's at like 8 out of 25, hey, they may not be ready to play.
Right.
And you also don't need to do this whole thing, right? It is kind of a lot. Like the Star Excursion Balance Test, like that's kind of a lot. Like you have to take leg length measurements, technically. Mm-hmm. You have to go, squat, and then you have to measure it, right? That could be a lot, especially if you're like by yourself. to do all that.
Right.
But like honestly, just being able to do like a figure 8 hop, like that doesn't take very long to do.
It just gives you a couple more things you can keep in your pocket when someone's like, I'm ready to practice today.
Yeah.
And you're like,
Timmy, you barely walked in here. What are you talking about? Yeah, so you can do that, right? Like doing just the figure 8 hop or the medial lateral hops, right? Like those are really quick things that like can still give you a lot of information without having to do the full thing, right? So I think that would be better than at least nothing than just kind of like Timmy comes in and says, I'm ready to play. And we're like, I don't know about that. You can actually now have them do something and be like, see, you're not that ready, right?
right.
Yeah. I think that's really where I think ankle sprain management's getting better, at least from the athlete perspective. I think less athletes are brushing them off. I think there's more that are taking them seriously. And I think this is why you're starting to see more research come out about like, oh, what are our return to play considerations and stuff.
I think more people are also going like up the chain too, like and noticing like how much it has effect on the glutes. I mean, I think if you've listened to any episode on this podcast, you will hear how much the glute affects everything, or at least in my head, it affects everything.
Oh, it absolutely does.
So like adding that into your rehab and not just focusing on the ankle itself. And I know that like these might sound like extreme, like after every single person, are you going to do like a return to play, like battery of tests for an ankle sprain? But really, like,
it's not realistic all the time.
No, it isn't realistic all the time. But also, I think we do have to take into consideration even some of those more minor ankle sprains, determining what it's going to cause down the line. Because if that does affect things like glute strength or lack of range of motion at the ankles, which really affects everything above it.
Yeah, absolutely. And
what are they gonna end up with later?
Yeah, absolutely. I mean, you got to think as how common ankle sprains are, right? Especially after the first one, right? We always tend to see, well, they've had 10 of them, right? They tend to have many of them. Like I get a ton of athletes coming in as freshmen that continue to have ankle pain from previous ankle sprains. They're like, yeah, my ankle still kind of hurt. And it's just like, that's tough.
Right.
Because now every time they've moved, that new faulty motor pattern is now their new motor pattern. So their brain having a huge area now for just simple tasks in the ankle is becoming their normal movement. And that inhibition is now normal for them. And that's not ideal.
And there's where it goes back to that update that you made on the treatment aspects of doing TENS around the ankle, doing cryotherapy around the ankle, doing things that really help with that inhibition.
Yeah.
And so then you can actually target, like get the pain down and target the things that are inhibited. So those are no longer going to be the main atrophy, going to be causing problems down the line and going to be causing their risk to increase for future ankle sprains.
And to your point with the glutes, we didn't talk about in this episode because we talked a little bit about it in the previous one. But yes, like that is still huge with ankle sprain because there is inhibition of the glutes after ankle sprain.
Because of dorsiflexion lacking?
Ooh, I didn't look. I would imagine so.
I mean, that's my go-to thought.
Yeah, I would imagine so, yeah.
I feel like so many motor patterns can just really drive your treatment. So if you really understand that biomechanical aspect and that background, I feel like you can get really far away with that.
Oh, absolutely. 100%.
Even like if you're lacking like your great toe, if you are not able to push it into the ground and like activate that kind of like flexion motion.
Oh yeah.
Like you're not getting your connection up to your glutes.
For sure. No, absolutely.
So some of the things that I do are like train with a TheraBand under their foot that's being pulled. And so like but it's only under half their foot or just under their big toe. Yeah. So if they roll on the outside of their foot, the TheraBand snaps back. And then so they have that feedback of like, oh, I have to keep
Yeah.
my big toe down.
Yeah, for sure.
What's your action item for this?
Don't forget the deltoid ligament, right? That's going to change maybe how you manage it, right? You're going to maybe stabilize that medial side a little bit more.
How would you do that?
I mean, maybe you have to go, like if walking is truly difficult, right? You might have to go boot until it's a little more comfortable, at least in a brace.
And when you're in the boot, you could do isometrics.
Or when you're in the brace, hey, making sure maybe the pull of the brace isn't just going one way. It's actually maybe keeping the ankle neutral. And then I would also say early motion as soon as you can. It's ideal if it's possible. The earliest you can do it.
Yeah,
Yeah.
that's a good point. Sweet. Well, if you guys are new, this again is a CEU episode, Category A. Thank you so much to Clinically Pressed and Athletic Training Chat. So go ahead and find the certificate link down in our show notes below. We also do other episodes here on AT Corner. So not only does Randy do education episodes where he reads a ton of articles and we talk about them and they're good for CEUs, but we also do story episodes where we bring stories from real life athletic trainers around the world and we talk about highlight topics and people submit their stories and we talk about those and how different people approach things. And we also do interview episodes where we bring in athletic trainers and some other healthcare professionals to talk to us about their highlight expertise topic. So coming soon, hopefully, we will have our episode directory because we have close to 250 episodes now. So sorting through those is fun.
Yes.
So if you are interested in finding some of our other episodes, and hopefully I get on this soon, maybe this will put a fire under my butt to do it. You find that episode directory, so stay tuned for that. And if you are looking for more of a subscription based for CUs, you can find down in the show notes below as well some other discounts such as MedBridge. You can use code ATCorner for $101 off your subscription. I think that's all I got.
Thank you for helping us showcase athletic training behind the tape. Bye.